Good morning. Welcome to clinical meeting organized by the Department of Medicine. So today, on behalf of Medicine 2, we'll be having a clinical presentation on a couple of PG theses which were done as a replication of the Q-tip study, which was earlier done by the Department of Medicine under the guidance of Dr. Thambu David. That's what will be presented. And to moderate the session, it's my pleasure and privilege to welcome Professor J.V.Peter, sir. In fact, sir was one of brains behind the initial Q-tip study that was published. And so we thought we could have no better person to moderate this session, which is in the similar domain. We had a previous presentation which was on the qualitative aspects. So today it will be on the quantitative aspects. And I'll hand over to sir to moderate this session. And I welcome Dr. Renju and Dr. Anna Paul, who will be presenting the study. I'll hand over to sir. And I'll let Dr. Renju to start off the proceedings. And we'll also open this for discussion once the presentation is done. And we welcome questions from the participants here, as well as from the virtual participants who have joined us online. Thank you.
Good morning, everyone. I'll be presenting on cost of medical intensive care in a tertiary center along with utility score and willingness to pay. This was done as a part of my MD thesis. I'll be doing the cost of care in ICU, and Dr. Anna will be doing the cost of care in ward along with the previous Q-tip study. I'll be talking just an introduction, my methodology, results, discussion, and conclusion. Intensive care as such, the idea of intensive care started way back in 1850, where during the Crimean War, this is Florence Nightingale, who was a lady with the lamp, who had started with the whole taking care of all the soldiers for the army who were affected in the war, where the idea of intensive care came when they needed an extensive monitoring for patients who were who had multi-organ dysfunction or their physiologically abnormal vitals. Then they wanted a more extensive care. So they say initial idea was at a nursing station, the nurses wanted all the sick patients towards their nursing station. So that's where the idea of, so that the monitoring is better than going all far away. Slowly this, later when the polio pandemic came, they wanted more ventilators, and that became a separate area to keep the ventilator. So slowly the whole intensive care came into place. And it became a place for enhanced monitoring for multiple modalities of physiological organ support. For the past few years, the demand for intensive care has significantly increased, mainly due to the pandemic, where the need for ICU, the need for ventilators, BiPAPs, ventilatory machines have gone up significantly. And due to the pandemic, social media, now the awareness among the general public also has improved or increased. Now, why this study was done? So, healthcare cost as such, it's a unexpected additional. So it's an unexpected cost that comes to a family. It's an unavoidable in case of emergency, which is for an Indian, we say it's an out-of-pocket expenditure. So mainly out-of-pocket expenditure means usually in the West and all, there's a lot of coverage by the insurance companies or the government. For us, the coverage of healthcare by government is way less compared to, so in 2012 it was almost 65% was our out-of-pocket expenditure, and the current government data says it's around 35 to 40% is our out-of-pocket expenditure. The rest is covered by the healthcare. Now, like every other system, we also have a public and private sector, where the problem with the public sector is most of our public or the government sectors focus more on primary and secondary care rather than the tertiary care. So when it comes to experienced staff, interventions, infrastructure, or like a high-end level care or intensive monitoring, the availability in the government sector has significantly come down. Even during COVID time, I hadn't put the graph. There's a graph showing the availability of ventilators in private versus public, which showed almost public sectors had only less than half of what private sectors had in terms of ventilators and ICU beds availability this is during the COVID time. Again, lack of experienced staff. All this will make the public turn, the common people turn to a private sector when they need a high-end care or an intensive care. Now, when they come to a private care, the problem with that is the expense. So ICU, the intensive care itself will cover almost 2/3. This was a study from 2008, and even in our previous QTIP study, they showed almost 70% of the cost of the total hospital stay was due to the intensive care or the ICU charges. This will lead to the poor accessibility for a common public to reach the intensive care in a private sector. So the data on the cost of ICU care is also limited in a country. There are few publications from our hospital recently which has been published on the cost of care. So we thought we need to estimate the cost of ICU in a private sector just to see how much is affecting the economy of a common household. Now, who will these kind of studies benefit from? Clinicians and healthcare workers. So in 2002 and early 2010, there was a study from South Africa. They have done a cross-sectional study, and one from Canada, which was a knowledge and at KFE study, where they found less than 30% of the intensivist or healthcare professional actually knew what they were prescribing, the cost of the investigation, cost of the drugs, cost of the medicine. So definitely clinicians and healthcare workers, not much of the proportion was aware of what we were prescribing. The common public, just to know that, understand the value of each disease or each clinical condition and the value of money they spend for that. Insurance companies, so that they can categorize each disease and estimate the cost that they have to give. And also the policymakers and scheme makers where in the government who can assess the cost of each diseases and accordingly plan out their policies in future. We did a prospective observational study with including 105 adults who were admitted under medicine in all 5 departments into the intensive care unit in our hospital over a span of 12 months. Exclusion criteria, we excluded patients who are non-consenting, people who stayed in hospital less than 24 hours. I'll come to it later. COVID patients, individuals who are covered by private insurance, because we are calculating the willingness to pay also. So we thought we'll exclude the patient with private insurance and patients who couldn't undergo the day 2 assessment mainly because of any other convenient reasons. Sorry for the busy slide. Measurements, we mainly looked at the demography, the patient and family's income, socioeconomic status by modified Kuppaswamy scale, ICU diagnosis and duration of stay and outcome, costings, which mainly direct medical, direct non-medical and indirect costs. I'll come to it later. Utility and caregivers' willingness to pay. So what do you mean by a clinical utility score? This is a score to, this just means how you can assess the global health of a patient. Mainly, we look at it's almost like a combination of a predicted life expectancy and a predicted quality of life, or how we prognosticate the patient during the ICU stay. So how he will be after the ICU stay. This is what we call it a utility score, where it ranges from 0 to 1 and goes up by 0.1. So it starts from 0, then 0.1, 0.2 till 1. In the previous study, so they have actually found that utility score had a good correlation with Apache score in aiding the patient outcome, predicted outcome. So we had used utility score in a study. How we calculated on day 2 of their admission, we had obtained the utility score from the ICU senior consultant or the floor consultant that time who was taking care of the patient. So a score of 0 means the predicted outcome is probably death or a severe disability. Score of 1 indicates a perfect health or good health at the time of discharge from ICU. Coming to willingness to pay. So willingness to pay is again a term used in health economics, where it means it's a maximum price a consumer is willing to pay for the service he gets or for the product he's going to buy, or it's the highest price a buyer is willing to accept for a service or the good that he's going to sell. Now, in our context, willingness to pay, how we calculate it is what we assessed is how much a caregiver is willing to pay for the service that we are giving according to the patient's predicted outcome. That is what we use as a utility score. And this was assessed by what we call a bidding method. So what we do is we will inform the caregiver about the utility score, which is obtained by the ICU consultant. So this was a little tricky question because how to bid during the ICU stay when the patient is already sick, it is difficult. So we had to explain that we are not a part of the team. This won't affect your final bill or affect your treatment. All that we have to explain first, and then we start on the bidding method. So bidding method mainly means a valuation technique where we interact with the subject and make some sequential increasing decreasing numbers till they reach the target of willingness to pay. So, for example, if an OP person, a young OP person has come and the ICU consultant has given a score of 0.7, and I'll get a cost bid from the ICU consultant, which will be, if suppose they say probably the bid will be around 3 lakhs will be the ICU charges if ICU is saying, I will speak to after getting consent, I will speak to the patient relative and say, this is the probable predicted outcome, or what we use the utility score. I'll explain to them and say, the probable cost is going to be around 3 lakhs. Are you willing to pay that much? Then from there, I'll start the bidding. If they say yes, I can go up. If they say no, I'll go down till I reach where their willingness to pay is. So this is to understand how much they were willing to pay according to the service we are providing along with the outcome of the patient. Sample size from the previous study, the mean cost the mean direct medical cost was 1,32,015 rupees. With that, with the cost is precision of 25,000 and confidence interval 95, we calculated a sample size of 105, which we achieved during the study. This is a stop figure where in 1 year there were 1,987 ICU admissions, out of which 1,050 patients are admitted under medicine. After the exclusion, which most of the exclusions were mainly because of COVID, because this was done during COVID time, and we have excluded the COVID patients. 12 refused consent and few did not fit into the criteria, inclusion criteria. Final sample size was obtained. 105 patients were recruited into the study, and a questionnaire, interview-driven questionnaire was given, and further data was collected from the electronic medical report. Coming to the results, so baseline mean age was 45 with 64% being male. Most of them, almost 70% of our patients were from Tamil Nadu. And this was again during the second wave of COVID. So there were some travel restrictions. So not many from outside. We got almost 70% are from local patients actually. In Tamil Nadu itself, most of them were in and around Vellore. Among the patients who got admitted, 50% were not the earning member of the family. And out of the people who are working or the breadwinners, 12% are farmers and 8.6% are daily wagers. Most common diagnosis we found almost 52.3% were infections. Again, there can be a selection bias because infections are usually reversible cause, and so we may tend to admit more of a reversible cause to our ICU. Among infections, we found scrub typhus was the most common infection we found, followed by lower respiratory tract infection. Among LRTAs, we had excluded COVID mainly because we didn't want any bias in cost estimation because it was during the pandemic. So we didn't want any pandemic factor to affect the cost estimation. So we excluded COVID-19. The other infections, they were all at the time of admission, there was no diagnosis, but there were a few cases of dengue, malaria, one case of malaria, one case of leptospirosis, and 1 or 2 cases of secondary infection in SLE. That's what the other cases we have found. The later diagnoses were deliberate self-harm, again, one of the reversible cause condition we see here, followed by acute heart failure, snake bites. Encephalopathy means at the time of diagnosis, if they're at the time of admission, if the diagnosis was either metabolic or toxic encephalopathy, that was put as an encephalopathy here. Comorbidity profile, almost 50, that is 46.7% did not have any comorbidities. Again, how we usually assess in our emergency where someone without a comorbidity may be preferred, or we think they have a better chance of surviving. So here also possibility of a selection bias is there. Almost 46.7% did not have any comorbidities. Among the people with comorbidities, diabetes was the most common, followed by hypertension. We had calculated a QSOFA score. Almost 58.1% had a QSOFA more than 2. Mean aperture score was around 15, indicating almost 25% of in-hospital mortality. And like I said, Charlson score, which is for the comorbidity index, 86% had a score of 0 to 2, which is a low Charlson comorbidity score. Only 2% had a higher Charlson's comorbidity score, showing severe comorbidity burden. The mean duration of stay we found to be 7.7% with minimum stay of 2 to up to 28 days. And ICU mortality, this is only during the ICU stay, the mortality was 4.8%. We didn't follow up post ICU. During ICU stay, the ICU mortality was 4.8%. Coming to the income, so for a monthly income for patient, the mean average income was only 15,000 per person. Most of them were daily wagers and farmers. And if you look at the socioeconomic class, 46% belong to the lower middle class, and 35% belong to the upper lower class. So most of the majority of our patients were actually in the lower middle and the upper lower class with around average income of 15,000 per month. Coming to the cost, so we calculated mainly three segments of cost. One is the direct medical cost. So direct medical cost means the cost of the hospital stay, the cost of the pharmacy bill, the cost of investigations, interventions, professional charges, nursing charges, all that come to the direct medical cost. That is directly for the medical service what we are paying for. Now, direct non-medical cost means the cost that they incur during the stay, but not because of the medical part of it. It can mainly be due to the travel they're doing during the patient's admission, the food, the accommodation, the utilities they buy, all that comes in the direct non-medical cost. And the indirect cost is due to loss of productivity, loss of wages. That means if when a daily wager is admitted who is getting paid 100 rupees a day, gets admitted for 10 days, he is losing 1,000 rupees. So that's a loss, or because of any other cost requiring a home care or someone has to look after the kid. So the child care or home care, that all comes in the indirect cost. Now, this is what we found in our cost study. We found the direct medical cost, that is a pharmacy and hospital cost. The mean cost is around 3.21 lakhs, 3,21,764, with the hospital cost of 24,000, sorry, 2,42,000, and pharmacy cost of 79,000. Direct non-medical costs actually came to very less, which is only 2,400. Among them, the major ones were cost of travel, food, and accommodation. Again, cost of travel, this was during COVID time, so there was very restricted travel, and most of them stayed in hospital. Cost of accommodation also was very low because, again, most of the relatives in ICU stayed in the ICU provided area, and there was only one bystander usually, so no one had taken any lodge or anything outside, and most of the lodges also were closed. Cost of food, they were mostly eating in hospital, either the from hospital or a subsidized food around. Indirect cost, again, almost 50% were daily wages, so indirect cost did not cost much, and the bystanders were usually unemployed, or it's usually either a housewife or a kid or someone who is not employed, so there was not much of indirect cost also. So the total cost of treatment came to around 3,25,196. Among we had looked at each diseases also. The highest came for the cerebrovascular accident, mainly in a cerebrovascular accident due to a hemorrhagic stroke, and this was around 6,66,000, followed by deliberate self-harm, which is around 3,30,000. The least among the diagnoses were snake bites, which was 1,57,000. Among the infections, meningitis was the most had the highest cost, which was around 4,20,000, followed by lower respiratory infections, which was around 4,15,000. The least was for pyelonephritis, mainly because of pyelonephritis stay of also was very less compared to the other diagnosis. Coming to utility score, so the mean utility score we found in ICU was 0.68 with maximum of 0.9 and minimum of 0.4. Diseases like meningitis and DSH actually had the highest utility score because most of them are usually reversible, and cerebrovascular accident had the lowest utility score because usually the prognosis for a hemorrhagic stroke who goes into ICU is usually bad. The post decompression and all usually we see as a bad prognosis. Coming to willingness to pay, so this is how much the patient's average willingness. So caregiver was willing to pay around 1,74,000. This was average willingness to pay for a patient. with ranging from, I'll show you the, for a 0.4 utility score, they were willing to pay 2 lakhs, and 0.9 utility score, they were willing to pay 1.6 lakhs. So if you look at the graph, actually as the utility score decreases, as the prognosis, or the, if it was a bad prognosis, the patient tend to pay actually more compared to a good prognosis. Even though there was no statistical significance, there was a trend to which they were ready to pay a little more when the prognosis score was actually low. Coming to just the discussion, so we found the direct medical cost was 3,21,000, out of which 24% was the pharmacy cost, and 76% was the hospital bill. Direct non-medical cost was very low. Like I said, most of the accommodation was in and around the hospital. Mainly they stayed in the ICU waiting area. Most of the relatives were in the ICU waiting area. They all had prepaid telecom, so there was not much of telecommunication cost, and the food was from the hospital or a hospital diet. Indirect cost median was around 2,000. Again, most of them are unemployed, so we did not have so much of indirect cost. So, like I said, the cerebrovascular accident had the highest cost, mainly because they had low sensorium. Most of them were intubated, and they also went into decompression surgery. So all that cost was around 6 lakhs. Snake bites had the least cost among the diagnosis. Meningitis had the higher cost because the pharmacy bill also added a lot. Mainly, we give broad spectrum antibiotics, which is usually expensive, and it's given for almost 10 to 14 days along. And also, they will have low sensorium. Most of the ICU meningitis patients were intubated. Again, ventilatory cost also added to it. Pyelonephritis had the least cost because of shorter duration of stay during ICU, because most of them only had they only needed inotropic support, which was tapered and shifted out immediately. So the average cost of care is 3,25,000. And what I want to highlight was, so the direct medical cost accounted for almost 98% of the cost. So indirect and direct non-medical cost was negligible. Almost 98.9% of the cost was mainly because of the direct medical cost. It can be due to some factors during pandemic, the travel restriction, the accommodation, all that could have been a factor. Again, so per day average cost was around 40,000. If you look at the QTIP study in 2013, published in 2015, the per day cost was around 15,900, which had come to around 40,996 now. And the total ICU cost in the QTIP study was 1,71,907. This was done 10 years back. So if we actually factor in the inflation rate of a country, which was around 6 to 6.5%, if we factor in this QTIP studies cost actually come to around 3,20,000 in our after 10 years, which is almost similar to what we have got. So we couldn't find a significant rise in the cost of care during our study if we compared from the previous study which was done. Total cost. This is the total cost of hospitalization, including the shift out to the ward, which was around 3,31,000. Again, this had shown that almost ICU took almost 98% of the total bill of the patient. So in QTIP study, it was 67 to 70% was the ICU cost, compared to what we found is almost 98% was the cost of ICU related expense in the total bill. This also, again, mainly most of the patients post discharge from ICU, they were immediately, most of them are stable, and they were discharged fast due to the pandemic and need for beds. So usually the discharge was very fast post ICU stay. So maybe because of that also, the ICU stay was the major chunk of our bill. Now the willingness to pay, if you look at it, caregivers are willing to pay around 52.57%. So if you, for a common household, they were only willing to pay 52% of the bill that we had told them. So this actually shows how much they are actually affected by the cost of care for a common household. In the even QTIP study, they found the willingness to pay was only 53%. Like that graph I showed before, there was a tendency to pay there was a higher willingness to pay for a lower utility score, maybe because of the emotional factors at the time of assessment. However, clinically, statistically, it was not significant. And other thing was, most of them, we found that the families had a predefined financial limit. Whatever utility score I tried to bid, willingness I tried to bid, most of them had one predefined financial limit, after which they were not able to pay. They were willing to pay only that much. That means how much they are limited to one out-of-pocket immediate expenditure, after which they were not able to pay with whatever bidding I tried. And what I wanted to highlight was the gap that is still existing. So if you look at it, the final bill, finally the caregivers paid was around 2,37,000, which is actually 71% of the final bill. So even though they were willing to pay only 52%, finally they ended up paying 71% of the final bill. And the rest was covered by the institution. So still, how much a gap is there between the if you look at it, the per month salary of a household was only 15,000, and the ICU bill was almost 3,21,000. So the gap between the financial status of a family and the burden by a healthcare expenditure, it's still a wide gap. So concluding, our out-of-pocket expenditure still severely affects the lower income population in our country, with a huge disparity, the wide gap between the ICU cost and the actual income of a family. Few things we can do. You can actually use this utility score and willingness to pay in our further hospital assessment. So which will help in utility score. Other thing we can use the utility score is where we can sort out patients and resource allocation optimization, where we can say if it's a low utility score, we can actually wait on them and give the person with a higher utility score or ICU bed, or some resource allocation can be done with the utility score. Again, willingness to pay. When we do a financial assessment planning for a patient, we can integrate in our usual system. Last thing is cost containment strategies. Like, because of this huge disparity that we are seeing, maybe we should do a personalized care plans for patients, limiting unnecessary tests, maybe adopting general medications, which is proven efficacious, and also cover some form of like a PTP or a health coverage. According to, we should do more strategies to make the care plan better for each patient. Limitations wise, again, the bidding method, how much actual they told us about their income and income and family income, we don't know, because most of them know that our hospital is supports charity. So it was even though we had to take some time to explain everything, we don't know how much actual financial data we got from the patient caregivers, because they may also try to give false data. So that is one limitation. Other one, we followed up the patient only till the ICU stay. After that, we didn't follow up fully. I want to acknowledge Dr. J.V.Peter, Dr. Tambu, and Dr. Vignesh for all this. Thank you.
Very nicely presented. Thank you, Ranju. I just want to make one comment before we open for questions. You said, how can we use the utility score in day-to-day practice? When we went back to Dr. Korean's QTIP study, we found that somebody who has an utility score of say 0. Can we talk to the family and say, do you really want to continue? Whereas if a score of 0.2 increases to 0.7 on day 5, you're going to continue care. So that is one application you can do. I want to ask the group one simple question. What is the difference between cost and price, or costing and pricing? What is your understanding? PGs? Can't say this. You can think. It's very simple and intuitive if you think. Cost and price, or costing versus pricing? Any volunteers?
What I think cost is the value of the product. The price is what is set by someone who's trying to sell it as well.
Very nice answer. Cost is how much I incur. If I look at the organization and I do a costing and say, to provide this service, this is my cost. So which includes how much it costs for the infrastructure, how much it costs for me to pay or salaries, how much it costs me to buy medications, whatever. So that's the actual cost incurred. But pricing takes into consideration how much I want to mark up so that I can end up with a little surplus to do all the other activities. So costing and pricing from a institutional perspective is different, but from a patient's perspective, this is the cost, actual cost that they are incurring. So it depends on who's looking at this whole question of what is cost. Okay. I have a few clarifications from you. Now, you said you recruited 105 patients. What was the method of recruitment? Was it a random sampling? Because if you're going to publish this, they're going to say, or was it arbitrary? You picked and chose whosoever you wanted to choose.
It's mainly convenient sampling, I would say, sir. We didn't
convenient
do
sampling.
a random sampling, sir.
So that has to come through. The other thing is you should fill up the stroke diagram. You can't have only 12 patients accounted for. You should probably fill the rest. The other question that I have is when Dr. Kurian did this study, I still remember in this hall, all the medicine consultants were also there. We put up scenarios and said, what do you think is the utility score? Did you do a method of standardization? Because if you don't do a method of standardization, I may think an OP poisoning should be given 1. Because in my opinion, less than 5% die. But you may say, okay, let's give a score of 0.7. So it's not standardized. And that may be a limitation if you have not standardized it. Now, how do you explain the difference in the predicted and actual mortality? Are you saying as an institution, we're doing phenomenally well, those who are expected to die, we took them through, you said the Apache risk of death was 25%.
Yes.
Their actual mortality was only 4.8.
Yes, sir.
So how do you explain that?
Even utility score, in the previous study, they had mentioned even utility score of at admission, if it was 0.3, almost 1 out of 3 actually did well and gone up. So it's more than utility score. I think clinical judgment is better.
So
Here, I was not able to explain how.
Anybody has an idea why? I mean, it's a very phenomenal survival rate compared to the Apache score. So,
And also, it was only the
ICU patients, whereas here we're seeing infectious and deliberate self-harm profile of patients. So the score at the acute admission, the score may be high, but their prognosis is obviously different.
that could be one possibility. The other possibility is whether our Apache is not performing as well for tropical conditions, because I think Apache was derived from Western populations with a lot of comorbidities, elderly population. Our population is younger, reversible pathology, they come in sick, but that could be one possible reason. I think that's a good point. I think there are a lot of good takeaway points from this. The first is the willingness to pay. I think what you could have possibly done is, actually you have done it. They were willing to pay 60% of the estimated cost, roughly, which is similar to Q-tip.
Yes.
But they ended up actually paying nearly 75% of the bill, which is phenomenal. What you could have possibly done is looked at each socioeconomic strata or the income strata to then say, somebody with the upper strata, did they completely pay the full bill? Or was there a gap? So that might give us a little better information to say, those who really need subsidy are the lower socioeconomic class, which is obvious. Even in our study, that was what was seen. The one way of getting this published, I was thinking was, rather than saying what is different from the previous study. Of course, there are inflationary costs and other things which are very nicely brought out. In the context of a calamity, a national and a global calamity, like a pandemic, was the patient's willingness or ability to pay change for non-pandemic illnesses? I think that may be a different perspective by which you present, which may make it more acceptable for publication. I'll stop here and I'll ask others to open up for questions and comments.
So the pandemic obviously would have affected the study. Apart from recruitment, there are issues on earning. We know that people in the informal sector were heavily affected in the pandemic. And so I just want to ask the question about how did you the how do you feel the pandemic affected your data set? What is your comment on the impact? For instance, let's say that patient, you said that they paid 50%, they were willing to pay 50% and they paid 70%. So now you have to think, if they paid 70%, where did that money come from? And did that have serious, one way to say that people can pay more than they say. But the other way, actually, maybe you may be causing more harm by asking people to pay more because it has effect. And was that effect much more in the pandemic? So I want your comment on how pandemic may have affected the results and your interpretation.
Willingness to pay, actually, we didn't find much difference from the Q-tip study. It was both 50, almost 53%. The financial status of the patient, when we assess, most of them were daily wage earners, and during the pandemic, all of them were unemployed. So that part, when we were asking the question, they had a severe financial concern due to the pandemic. Like they were not able. So most of them who paid, at least I couldn't post this thing. I couldn't meet everyone post discharge from ICU. But whoever I met, most of them said they had actually sold lands, sold cattle, gold. So that was one way of them paying because they were all unemployed at that time. Most of them, almost 12 to 13% were daily wage earners, farmers. So it was mostly selling the land, and that's how they were trying to cope that time.
Yeah, so that's what we found in our study of opioid poisoning, that the outcome was good, and people were able to go back to work, but they actually incurred significant debt which could not be repaid over a long period of time. So I think it's important to comment on that. So coming back to your conclusion, you said that like we can use this kind of a scoring with utility and willingness to pay to look and see who needs support and how much support. So I think that works, this discussion, like, you know, when you're saying that people, should we be looking at that more carefully and saying that, I mean, we do it regularly on rounds, but this kind of scoring could help, and then looking for supports, because it looks like across the board, at least for the people who are daily wage, we need to be doing these calculations regularly.
Just one more comment. If you marry this with the qualitative data which we had from the first Q-tip also, people were asked, what do you feel about care? And then we asked the patients about how much you're willing to pay. Many of them gave the other comment, like, this is my grandfather. He looked after the whole family. So now even if you say score is 0.2, I will pay whatever, so much money. So we thought that if they're very sick, they'll be willing to pay less. And actually we found the inverse for the ICU and the unit doctors. Suppose I say your utility score for this young girl with OP poison is good. Then the unit is willing to write off more bill, like in a sense, than for a person with the esophageal cancer with pneumonia, we're not willing. So there is some psychology behind that. So these patients don't seem to get this concept of, you know, if the patient is not going to do well, we won't pay more money. They seem to have a little more philosophical bent of mind. Yeah, it's a family member, and irrespective of what they say is the outcome, they are going to pay some amount. So it's some different idea.
That's a very important point which you can highlight. Caregiver is willing to pay more for a severe illness, but the healthcare professional is willing to spend less to subsidize for a more severe illness because they feel the outcome can be poor. That's a good point.
I wanted to say that this paper had a really important influence in a lot of us as we read it, and I'm sure as the team took it forward. The term utility score is something which has been developed in CMC. It's not a standard score that is used. And actually, I want the team to think about it, because what you're combining is three measures: probability of discharge, quality of life, and longevity. So I want to caution that it's not a simple score to put all together. Two is, in the previous study, different teams had different utility values that the Q-tip had. The second bit is the concept of willingness to pay is traditionally done in a population which isn't under duress. And as you can imagine, when you ask somebody to how much you're willing to pay in an ICU setting, you cannot get a rational answer. And rational being when you're not having any other pressure. And the concept of affordability. And this is something, again, which is not discussed in the West, because your willingness to pay for this disease can be million, but you're not asking about the affordability. So what we are looking here is actually a bargaining method. So if you go to the street hawkers, if you say 400 rupees for this piece of shirt, I'll give you half price. And that's what we've found. So I think teasing out affordability, which you've linked to the annual monthly income, then converting that into an annual income and looking at the catastrophic nature of the care. So if you've got 2 lakhs as an annual income and your cost is about 3 lakhs, you've already gone 150% the annual cost of a patient's household. So affordability versus willingness to pay is the second concept that I wanted to look at. And the final thing I want to know is how reliable was the team in actually projecting the cost to start the bid? That would have been an interesting thought to look at. But great study. Thank you so much.
Very nice points. I wanted to highlight this point about utility. It's how much are you willing to pay to normalize health? So it's not just getting out of hospital or mortality. So that is, it's a wholeness. I clearly remember Dr. Kurian articulating this again and again. It's not just mortality. It's restoring health back.
A very nice study and well presented. Thank you, Renju. So I just had this one thing. So were these people followed up in the ward also? Because like Sir was saying, this is a restoration of health. So when they came out of the ward to the ward, till because this whole thing is for their overall hospitalization or only for ICU stay was my question.
We had only looked at till their discharge from ICU. In ward, we hadn't looked at. The final cost is actually retrospectively looked. So during ward, I didn't follow them up. That is one of our limitations. We couldn't follow.
Thank you.
It's a very nice study, Ranju. I was surprised actually that the adjustment of cost with inflation was actually similar to 2015, considering most of the patients actually were young and not having too many comorbidities. Thinking that, like you mentioned, maybe because of the pandemic and restricted number of beds, there would have been profiling of patients to admission to ICU. But looking at the sort of patients who now get admitted with the volume of comorbidities and severity of illness, I would have expected it to be different. The second was, you had mentioned that the sicker patients actually, they were willing to pay more. My doubt is, for patients who had a higher Apache score, based on the severity of the Apache score, how much more cost was there, which did the patient finally need to bear? Like, for example, 25 to 30 Apache score, was the final hospital bill 50,000 more or 70,000 more, or anything like that?
I hadn't included it. That too.
The reason why patients were willing to pay so much, be the pandemic itself, just because people realized the importance of healthcare so much, and they were, and the beds were few, so they were like, we're willing to pay whatever it takes. It's just a thought, because I don't think post-pandemic, if we did the study now, we might not get as much. Whereas during the pandemic, I think health as such became a much more relevant topic.
Maybe providing the platform for another study. From online, anybody has any questions?
J.V.Peter, am I audible? J.V.Peter, am I audible? Am I audible? Hello.
Just 1 second, sir. They are connecting. We'll try and exhaust all the questions here so that Anna will just present. I didn't realize there was a time restriction up till 11. I thought it was a longer one.
Even in ED, like if they're on the lower end of the financial thing to say, and especially if you thought the prognosis for basically non-COVID pandemic patients, the number of beds were very few. The IP admissions per unit were like 8 and 10 and all at that time. So whether it truly represents the population we are studying is a big thing because of the limitation of the pandemic again. Maybe the better off people are the only ones who came to hospital at that time. It was very
Very nice point. Maybe you can add that maybe we moved from an equity principle to a utilitarian principle and said, okay, the ones who are most likely to survive are the ones who are going to get the bed. We don't know. All these are speculations, but these can be put as possible reasons. Yes, from online.
Am I connected with audible?
Yes, sir.
Yes, K.R. John. We were part of the Newton study 10 years back. The bystander cost, as I am worried about the indirect cost being so low, because for every patient there are 2 or 3 bystanders waiting outside. And it is not just the cost of this patient alone, the family cost counts. So is it something which can be taken into consideration in the next phase of the study, so that the terms of the ICU cost includes that also. Otherwise, it's a wonderful study, and I'm very happy that a new team has taken over the study, and very well done study. Thank you.
I think we'll give a round of applause to Ranju. We'll move on to the next presentation, and we might have very few questions for you. You can go through your presentation maybe a bit faster because the methodology is the same.
That's a very hard act to follow. So just a disclaimer, this was actually a study. This is Dr. Praneet Kashyap's thesis. He's not here at the moment, which is why I'm presenting on his behalf. He had titled his study Cost from a Societal Perspective of Medical Ward Care in South India. Dr. Tambu was the guide. I'm not going to... I'm not going to go into the details of context and rationale. I think Renju had covered it. Just to point out that this was a ward-based study. So there are a lot more ICU-based study data that's available than ward. Although having said that, I think after the study was done, there was some large, 2023, there was a large study that looked at multiple hospitals across India, including 16 private hospitals. Aims and objectives of the study was to calculate direct medical, direct non-medical, and indirect costs, as well as assess the willingness to pay relative to the clinical utility score. Methodology was a cross-sectional study. They used the Strobe and Chair checklist to write the methodology. It was 110 patients, all patients above the age of 18, across all 5 medical units, and it was done from September 2021 to November 2022. So from his thesis, he only mentioned the exclusion criteria has died within the first 24 hours and no consent. But I believe similar other exclusion criteria were also similar to Renju's, which is no COVID patients were included, but he hadn't specifically mentioned that. Again, data collection with demographics, SES, diagnosis, and only Q so far. I think Renju had Apache scope that was not done in this study. And again, at day 2, the clinical utility score is calculated, and this was done by the ward consultant, is what was mentioned. And a willingness to pay was done on day 2 as the bidding method, which Renju has already covered. This is a stroke diagram that we have. Again, a lot more details need to be filled in, like Dr. J.V.P. had mentioned, but he says around 7,000 patients were admitted under the medicine units. And he had calculated a sample size of 110, which was met. And baseline details were calculated. And he, based on the interview, he got direct medical costs, direct non-medical costs, utility score, willingness to pay, and the discharge outcome. So I'm going to jump right into the results. The demographics wise, most of these patients I want to highlight were in the 31 to 60 age group. That is the income generating or the age group that's primarily working. And most of these were from the upper, lower, and the lower middle income socioeconomic groups. And this is a graph that looks at the monthly income for a family. And it's important to highlight that most of them, almost 90% of them, had an income that was less than 50,000 per month. So when you look at that compared to our admission costs. So the cost breakdown, the median cost for the ward was 78,610, which with an interquartile range of 40,000 up to 1,30,000. And like in the ICU study as well, the direct medical costs contributed to the bulk of the expenses. So the direct medical costs constituted hospital charges and pharmacy charges. Similar to ICU, most of it was the hospital charges, and the pharmacy was only around 14,000. The direct non-medical costs was travel, accommodation, food. Surprisingly higher values compared to the ICU study. Maybe the patients were finding accommodation outside and traveling. I'm not sure how to explain the difference between ICU versus the ward. Indirect cost was the wages loss, which is again 3,800. Could be because they didn't have a source of income, or that the person usually at the bedside is someone who's not a wage earner. So the primary diagnosis, again, like in the ICU study, around 50% of the patients were infectious diseases, and the next bulk was actually CNS, which was strokes. Among the infection disease profile, all the usual suspects were there: acute pyelonephritis, dengue, community-acquired pneumonias, cellulitis, and STI. But it was interesting to note that only 5% of them had scrub. Is that because most of them went into the ICU that year? Or since it was during the pandemic, they were maybe not going outside as much? I'm not sure how to explain that. Quite a low scrub incidence. We don't have so Pranit hadn't done a cost breakdown for each disease, like the cost for pyelonephritis, the cost for stroke as such. He just had a overall cost for infectious disease as a group and overall cost for CNS disease as a group. So that was around 87,000 for the infections and 86,000 for CNS, which was mostly strokes, which is quite similar to the overall cost, which was around 78,000, which is obvious considering it contributed to the bulk of the admissions. So coming to the utility score distribution, there was a reasonable range of it, but the main utility score was 0.6 with a standard deviation of 0.2. And there were a few which had outlying values, but most of them were around 0.4 to 0.8. So the utility score is actually slightly lower than the mean utility score for the ICU, which was around 0.68. Coming to the willingness to pay, the patients were willing to pay around 50,000 for the ward admission with a range of 30 to 80,000, which was significantly lower than the ICU, which was around 1,75,000 was the mean willingness or the median willingness to pay. When we looked at utility score versus willingness to pay, so on the x-axis you have the utility score and on the y-axis the patient's willingness to pay. Here we found a clear association. So the p-value, when we looked at, so patients with a lower utility score, the caregivers were willing to pay a lot more. As the utility score improved, they were willing to pay a lot less, and this was statistically significant with a p of 0.003. So again, I think this was already highlighted in the discussion, Thambu sir and J.V.P. sir had mentioned, but maybe the decisions were more emotional from the patient's relatives. So they were willing to pay a lot more when the patients were sicker. And they were, and perhaps for patients with good outcomes, they thought they needn't invest as much money. They could get treatment in a government or could be treated as an OPD basis. These are just possibilities. When we looked at cost versus willingness to pay, so on the x-axis we have overall cost versus the median willingness to pay. There was significant variability. There's perhaps a trend showing some sort of a relation, but at each point, as you can see, there's a significant variability. Is this perhaps because we're not explaining financial counseling, is it not done enough, is one thing that I thought when I looked at this study, that patients seem to have very poor understanding of what the actual cost incurred for that particular thing would be. So maybe we need to counsel our patients a bit better. And this is a graph that looked at final bill versus lower utility score. As expected, a lower utility score was associated with higher costs, and that is something that seems intuitive and has been found across other studies as well. So this is actually just looking at the final cost versus utility bill and willingness to pay across utility bill. So it seems, there's almost similar pattern that they're following. Again, I guess patients also seem to understand the concept that when someone's sicker, it is associated with the higher cost of care, and their willingness to pay for it was also accordingly so. So coming to the discussion, I think Renju had covered quite a lot of it, but I just wanted to compare across the two studies. Something that I thought that was interesting was the mean utility score was around the same. In fact, the ICU was a little higher. So you would assume that ICU patients were sicker, therefore may have a lower utility score, although I know utility score is also looking at discharge and longevity and multiple aspects to it. But whether subconsciously we had a different score because one was done by the ward consultant and the other was done by the ICU consultant. So whether we have a different scale was one possibility. The other thing is whether it reflected the disease profile, because predominantly it was infections. So perhaps, we all felt that dengue will do better or scrub will do better. Again, like I said, infections contributed to most of the cases. And the willingness to pay both in the QTIP study and the NGO study, although there was maybe a trend, it was not statistically significant, whereas in the ward, very clearly, lower utility score was associated with better willingness to pay. This is the QTIP study that everyone's been talking about, which was published in 2015 by Dr. Kurian and Dr. J.V.Peter et al. So they, as was mentioned, I think the utility score was calculated by 3 different people. So at any given day, the ICU nurse, the ICU doctor, and the unit or the medical doctor had given their scores. So they had calculated it over day 2 to day 7, not just a one-time utility score. And so this is the medical doctors who are on top, the ICU doctors were below, and the ICU nurse is the red one. And again, it's around that 5.5 to 7 was the utility score across all the studies. Is something that I thought was interesting to note. And when they looked at willingness to pay, so one thing that the QTIP study had done is they looked at willingness to treat from the doctor's perspective. This was already alluded to during the discussion. And as you can see, the patients were willing to pay a lot more than the doctors to spend. And the blue is actually the medical doctor or the unit doctor. So they were willing to spend a lot more as the utility score improved. Whereas the ICU doctors, which is the green, they had a sort of a U-shaped curve. So for the utility score somewhere in between of 0.3 to 0.6 or 0.8, they were willing to spend more. But as the utility score improved, the ICU doctors were willing to spend a lot less. Now, whether this is a reflection of the unit doctors are the ones actually dealing with the finances or writing off the bill, so therefore they were willing to spend more when the patient was likely to have a better prognosis, I don't know. It's just but it's interesting to note that there was that significant difference in the graphs. And this is actually comparing willingness to pay versus the utility score across all 3 studies. And this is just from the patient's perspective. So this is the ICU study from 2015, the QTIP study. So that is the patient's graph is the red one. This is a Renju study, and this was the ward study. So very clearly among the ward patients, as the utility score improved, the patients were not willing to spend as much. Whereas ICU, regardless of what their utility score was, they were willing to spend a lot more, perhaps because they associate ICU with higher charges or sicker patients, therefore they were willing to do whatever it takes. Whereas in the ward, a little bit more rational thinking than emotional decision making could be why this difference was noted. So the key results were that the median cost was around 78,000, which was still higher than the monthly income for the average family, which is less than 50,000. So even a ward admission incurred quite a lot of expenses for the patient. As expected, the direct medical costs were the major contributors, and I've already highlighted this, that the utility score was inversely correlated with willingness to pay. From a stakeholder perspective, why is these studies important? From the doctors, I think we need to have better financial counseling. So even from the registrar's point of view, when someone is coming into the ED, I think it's important to let the patient know that this is the cost. Like we've done studies, it's actually a lot more than what very often is being conveyed to a patient. From a government insurance point of view, it's actually the funds allocated for each thing needs to be a lot higher. So I think, we're not taking up any of the Kalainer Kapitathittam or any of those things because the amount we get back is so little. But it's important to tell them that this is how much it actually costs. So therefore, that might encourage them to allocate more funds. And I think for patients, it sort of helps them anticipate what even a ward admission would entail. This is a single center study, but again, generalizability anyway would be affected because but a government hospital, tertiary care, city versus non-city, for-profit, not-for-profit institution, there would be significant variability across this anyway. I think the physician's willingness to pay would have been something that would have added a lot to this study, like in the QTIP study. We don't have outcome, like maybe if we had done a QALY or something at the time of discharge, so additional studies like cost utility, cost effectiveness analysis could have been done, which we weren't able to do. That would have added value to these studies. I'd like to acknowledge Dr. Tambu and Dr. Vignesh and Dr. J.V.P. as well, even though he said, please don't put my name. And of course, Praneeth, who actually did this thesis.
Thank you. Another excellent study. And while we get the online people on board, I have one thing that is intriguing me. Maybe you can clarify. You said as utility score increases, their willingness to pay decreases. Now, is that an epiphenomenon? Now, what I mean by this is you're going to start a bid based on how much you think it'll cost. So if you have a utility score of 0.9, you're not going to start with a bid of 1.5 lakhs. You're going to start with a bid of 50. Okay, whereas if you have a person who's very sick, you may start with a bid of 1.5. So do you think it's more an epiphenomenon rather than actually a true reflection of willingness to pay? Maybe you people can comment. Vignesh?
I think for the ICU, we started off with a median ICU cost from the previous year. So the bids for everybody started at, I think, 50,000 in the QTIP study. Here they have taken the consultant's expected bill, and that was the opening bid. So maybe that is the reason for the two difference in the billing. Maybe that's why that could explain that. Yeah, you're right. Just some few comments, if I may add.
Please.
One, I think we should. I want to thank Dr. Kurian, who is not here, and Dr. Peter, because in the initial study when we started off, nobody knew how to do this economic studies and how to analyze this data, and also Dr. Kurian, Dr. Peter, Dr. J. Seelan, they really took a lot of time writing those two papers, and getting them into good journals was a huge amount. So we sort of built on that only here. One of the criticisms, the initial study, we did qualitative studies of only the patients in the ICU. They said you didn't ask the doctors and nurses. So this time we've added that. And actually there's a qualitative component to this ward study as well, which 1 month ago or 2 months ago, Janvi and Sakshi presented the qualitative aspect of this. The second comment is that we don't have that many very poor patients. Maybe because of COVID, the very poor patients all went to below poverty, or that level went off to the government healthcare system, which was everywhere in the world. I mean, India, poorest people went to government healthcare sector for care. So that's the other thing. The median bill seemed to be not so bad. Everybody seems to be adjusted for inflation. Our ICU costs, our ward costs haven't gone up much, which is, I think, a good reflection of our CMC care, that we are not, our people think we are very expensive, but actually adjusted for inflation, we are not doing so badly. Like so. Otherwise, I want to thank Peter, Anna, to a tough job of presenting Praneeth's thesis, and Renju did a great job. So excellent. Thanks.
No, I just wanted to ask because of this inverse relationship between the score and the willingness to pay. Did the relatives change? Or, I mean, what I'm not trying to ask is like when the patients were better, was there a distant relative who was staying with them? And because of that, I'm just putting in a factor to say, was that one of the reasons to willingness to pay was much less? Did you look at the closeness of the relationship between the patient attender and the thing? That was one point I had. A very interesting thing that you had put that overall it was costing only 15,000 for medicines in the entire ward stay, like, and the cost of hospitalization was 45,000. So I was wondering whether the patients were on oxygen, which was increasing the cost of hospitalization and things like that. And the wages were also extremely low, 3,800, which is quite low even compared to the Indian standard average.
I didn't actually collect the data, but I think Renju also had very similar findings. So, and whether it's because a lot of people had lost their income during the stay, or the other thing is whether they were just not giving the wages of all the family, as opposed to just the person who's standing there, who very often is someone who's not bringing in money anyway. Perhaps.
Any questions from online?
John,
Yes, sir.
one comment about the indirect cost in medical studies. Suppose if they are all women and they are not at all working, does it mean they don't have any indirect cost? Because there is a lot of time spent. So one of the ways to handle the problem is report the actual days lost instead of going into the wages loss. So if you look at that, so many studies are reported like that. So maybe that is what we can always do in our papers. And creating evidence for indirect costs for reimbursement. So all our reimbursement is for direct medical costs. So the best insurance should cover the indirect costs to bystanders and family costs. This is a very unique situation in our Indian context. Families become poor, so that component probably somebody can take up and start the work. And also all these are charges. These are not true costs. So if you want to really do a true cost, how do you go about? Because these are all charges from the point of view of the patient. So the patient has paid all these things, not the true cost probably for our institution. So that's the other challenge which I am putting forward to the new study teams.
Thank you, sir. Anyone else from online? Manila, Abraham? I think indirect costs are probably grossly underestimated. Your food cost was only 300 rupees for the whole stay. Unbelievable. Who will get food for 30 rupees a day? So there's some problem there.
Be failing if I didn't thank some people. One is Dr. John helped us to design the initial Q-tip study. So thank you, sir. Based on your ideas, we have taken this forward. Let's give sir also a round of applause. The other people we must thank is the ICU consultants. They did for the initial Q-tip study. I remember Peter and Kishore running the utilities course scenarios we did in the CU. We were doing that. So that's the same principle we followed. So thank you. Even now the ICU consultants helped Renju by doing that. And all the data collection during COVID was very difficult. So we must thank the ICU staff. And for the C ward and all the general medical consultants from 5 units, everybody helped out collecting the utility scores in the ward. So thank you to all the ward consultants, all the ward HODs who helped us a lot. The statisticians, Dr. J. Seelan helped us a lot. And also a round of applause for Bijesh, who spent a lot of time doing all this analysis. So Bijesh is not here with us. He's online with us. Thank you, Bijesh. So thank you to you also for helping us to do the analysis. Thank you.
Anyone else from online want to make a comment or? Okay, thank you for this excellent session. I apologize that we overshot by about 10 minutes. Thank you so much.
Thank you. It's again a special thanks to Dr. Renju and Dr. Anna for that presentation. And I'm also indebted to Dr. J.V.Peter, sir, for kindly agreeing to our invitation and coming to this presentation. Thank you very much, sir. And also to Dr. Tambu for having suggested the topic as well. Thank you so much. And to the Department of Medicine 5 for having given us this opportunity to present on behalf of our unit. Once again, thank you to all participants who have taken your time to attend this presentation. And we'll meet at the clinical meeting session next week. Thank you.